Bismillah ar-Rahman ar-Rahim. Our presentation today is about FOCUS PDCA as a rule model. A lot of people is asking how we will do a project of improvement through using the FOCUS PDCA. So today we will give just a rule model, an example for a real project, how to perform this project step by step, inshallah. Before we have to start this presentation, we have to say that it's the responsibility of who have to do projects of improvement, and the answer is it's the responsibility of all. Every single person working in a healthcare facility should share or should establish or should discuss or should collect data for improvement, because if we are working on the same level for a long time, this means we are static. We are in a static state. We have to continue, we have to improve, we have to grow up. So through collection of data and doing projects of improvement, we can grow. So is it mandatory to do projects of improvement inside the healthcare facility? The answer is yes. Here in the Kingdom of Saudi Arabia, we have a memo from the Central Council or Council of Ministers that accreditation from Sibahi is mandatory. So it's mandated to achieve Sibahi certification for accreditation. And a lot of standards inside Sibahi is talking about projects of improvement. I'll mention here only one or two standards to show you that it's mandatory and we have to work on it. It's not an option, it's not a choice. For example, Leadership 31, the department head ensures performance measurement and improvement of the outcome of the department. How he will do this one? Performance measure and the improvement are consistent with the hospital-wide quality improvement, patient safety and risk management plan. He will do it according to the models of quality or improvement methodology, and inconsistent with the continuous quality improvement program or safety program or risk management program, even scope of service and strategic plan. Leadership 31.4, performance measurement and improvement involves regular data collection. So we cannot work without a data collection analysis. So we can use those data or analyze data, which is information and knowledge, to make the improvement projects. LD 31.6, results of improvement measurements and improvement are reported periodically to hospital leadership, hospital director, some committees, or even the governing board. Another standard, which is QM1, hospital leader supports the hospital-wide continuous quality improvement program, and this will not happen until providing resources for the improvement program and participating in improvement activities and projects, implementing the recommendation coming out from the programs and improvement project, and leaders support staff to make and participate in the quality improvement initiatives and to attend the quality improvement educational activities. If you go to lab also, you will find one standard in lab talking about that the lab should prepare 4 improvement projects while Sibahi is visiting them, 2 general services inside the lab and 2 for blood bank. So it is mandatory to do improvement projects. We have a lot of methodologies doing improvement projects. We can use Six Sigma, Lean Six Sigma, we can use Xerox, we can use a lot of methodologies, but we are almost in our quality improvement program inside our healthcare facilities. We use FOCUS PDCA. So why PDCA? FOCUS PDCA, because it's simple, we can do it. It's easy, we can do it very easily, and we have a lot of trials. We have experience in it. We did a lot of projects using this methodology, so I prefer to use it inside our healthcare facilities. So what's FOCUS PDCA? It's letters, every letter referring to a word or a sentence. We should implement it to have the step from the improvement methodology. So the first letter is F. F mentioning or meaning finding opportunity to improve. What the people call in the hospital problems, we call it chances of improvement. We call it initiatives. We call it opportunity for improvement. So they will, that we have a problem related to blah, 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 blah. We will take this one and we consider it to an improvement project. From where I will got the sources of my improvement project. I'll go to get the data for the improvement project from logbox, from OVR and risk registers, from SIBAHI results, from patient complaints, from satisfaction surveys, whatever patients or staff, from KPIs and indicators, and from medical record and HIS. All of those are sources to take information and data from it to start your improvement project. How to select if you have 3, 5, 6 improvement project? What you have to start with, we have a lot of things like voting. We can vote, which is important to the facility, and according to the voting we can start with, or you can select or use the selection matrix, and within few slides we will discuss in detail the selection matrix while we are selecting some remedies and solutions for the problems we have. When we are going to target an improvement project, it's preferable to use the big one, the important one to the healthcare facility, and we can use the high risk, high cost, big volume, problem prone issues. So when you are doing an improvement project, start with the project that considering a high risk to the patient or to the facility or to the visitors or staff. High cost, if it's giving a high cost, it can cost us a lot, we can start with it. Big volume, something is happening every day and we need to improve it, like patient admission, patient transfer, patient discharge, waiting number in OBD. All of these are big volume and it can affect the facility, so we can start with them. And at last, a problem prone, if any process inside the healthcare facility giving us a lot of problems, we can start our improvement project for them. So those are the selection criteria for the improvement project. So this is simply about find opportunity to improve. What we are discussing here, we are giving you a role model. We are giving you we established an improvement project. We put number. We did not implement it. It's theoretical. Theoretical just to give you how to start it and how to implement your steps, step by steps. So for example, I will give you fine. My problem is the cesarean section benchmark inside the kingdom, let's say it's 25%. And this is our performance inside our healthcare facility. For 18 months, 1.5 years, this is our performance. January 2019, it was 36%. In February, it's 40%. In March, it's 38%, and so on. So this is our performance. And the benchmark is 25. So this means we are far from the benchmark. So our target, this is considered a problem. They will call it inside the healthcare facility a problem, but we call it's the opportunity for improvement. So we found now an area for improvement or an opportunity. So we will put it, just if you have the data information, month by month, just to put it on a bar chart like this, or line chart according to your capability, according to the programs you have, or even simply on Excel sheet, you can put them to know what's going on. So as you see here, from January 2019 up to June, it's supposed to be 2020 because it's 1.5 years. Okay, no problem. So now we have 1 year, and the last 6 months should be January 2020, February 2020, and so on. So let's guess that we have those data and information. We will do. Why we are selecting as we said before, the improvement project according to high volume, high cost, problem prone, and media effect if it's affecting the media. Step number 1 is focus, which is find opportunity. Step number 2 is organize the team. Now we have to make a team discussing the causes and putting the remedies and solution for this cesarean section increased percentage beyond the benchmark internally. So we have to organize the team. The team should be like this. You have to put serial number, name of the person, and his title. We selected here 6 persons only for the team. Of course, 1 from the leadership, like the head of department. We can put medical director, hospital director, according to your capability inside the hospital. We have to have a facilitator from quality department or risk management because they know the tools for improvement. So some facilities will give the accountability to the facilitator to establish the project. No, the project is concerning the department having the opportunity, not the facilitator, not the quality department. Quality department should send a facilitator because he knows the tools, he can explain how to use the tools and when to use the tools. We have obstetrician number 1, obstetrician number 2. We have someone from OR technician, and a nurse. Now we have the team. We have to tell the team what's your mission, what we need from you. Of course, we have to have a team forming form, and this form should be filled by a committee. The committee will issue or give delegation to the team to do the improvement. We have to fill the form. Who will do what, when, why we choose it, what's the mission of the team, what the team will do, the due date for finishing the department, and we should sign it from one committee or from the hospital leaders. It's acceptable, approved, or not approved. And why? What's the team mission here in our project we are trying to discuss with you is reducing the cesarean section rate to less than 30% within 3 months. From now, we have to do it. So this is the target. This is the name of the project. This is the target. This is the mission of the team. Every goal we are doing, we have to consider to become, to give a SMART goal, a SMART project of improvement. SMART is referring for S for specific, M for measurable, A for achievable, R for realistic, and T for time bounded. So now our project is specific because we are talking about cesarean section, and we are talking about numbers, and we are talking about time bounded. Measurable, we can estimate it because we can gather information again about our performance. So it's measurable. It's achievable. We can decrease our performance from beyond 40 or beyond 30 to less than 30. Realistic, we can do it because it's inside our healthcare facility, and time bounded, we bought 3 months for it. So now we finished F, find opportunity, O for organizing the team. Step number 3 is C, which is clarify the current process. What's going on? What's happening inside your hospital? Not the ideal. No. What's right now going on step by step in a flow chart. So we put here a flow chart. Maybe it's happening in your facility or not, but what's requested from you is to put the real flow chart of the process happening in your hospital. We said here that patient may come for an appointment. They are coming for cesarean section on appointment. So they have an appointment from the department or OBD 2 weeks or 1 month before, or they came to emergency room as a cesarean section or a new case. What will happen in our healthcare facility? The patient is examined by resident ER. The resident ER will check. If the patient is coming according to the appointment, he will send her for investigations. When the investigation will come back, if it's non-remarkable, this means nothing big in the investigation, we will send this patient to OR to have the cesarean section. If no, there is something wrong with the investigation, we send her to ops specialist or consultant. But if the patient came to ER in delivery, or she needs cesarean section, the resident will estimate if she needs a cesarean or not. If she needs cesarean, he will send her to the OR. If she doesn't need, he will send her to DR. So this is verifying the current process through making a chart. Again, make sure that this project we invented, we created. It's not a real one. It's a role model. It's an example that you can train yourself upon it. So this is our flow chart here. Again, understanding or uncover, we have now to dig down to reach what are the real causes of our increased percentage of cesarean section. The income interest here. Just check the, yes. It's considered, yes, 2%, 14 for the income. So this is the Pareto chart. Then, when we finish the Pareto chart, to put it like this, the bars is the frequency and the line graph is the cumulative. Now we have to draw line when we reach 80%. We said that 80% we have to put a line until it will meet the line graph, and we have to get another perpendicular line. The column on the left is called the vital few. Vital few means the most important causes that if I correct them, 80% of the process will be improved. And we call them vital few. As you see here, it's only 3 causes and the plus. 1, 2, 3 with half of the fourth one. So if you correct 3 or 4 causes, the most important, we will improve the process itself by 80%. What about those causes, the small one here on the right of the perpendicular line? We call them useful many. It's very useful. We can work on them, but later on, after we will finish the most important few. So now we will go to the next step, which is select. Select the best remedies. We have causes, so we have to put remedies for them. And as we said, we will use the selection matrix. Before starting or explaining selection matrix, we have to agree upon one very important rule. We will classify issues now from 1 to 5, while 1 is bad for us and 5 is good for us, or 1 is bad for our facility and 5 is good for our facility. Deal? Because we cannot hesitate while we are doing it. 1 considered bad, 2 much more better, 3 much more better, 4 it's okay, 5 it's excellent for us. Deal? Deal. So let's show our main important reasons. We have to put solution for them. If you remember that the most important 4 causes is no policy procedure, defective antenatal care, no departmental orientation, defective staff. So what will be the solution? No policy, we have to put policy and the procedure. No good antenatal plan and care with implementation, we have to put effective plan and implementation. No departmental orientation, we will do departmental orientation. The staff is defective, we have to put extra staff. Okay? So we have to evaluate every single solution of this one. The cost, let's take it one by one. To make policy and the procedure, we don't have to have any cost. It will not cost us anything. Just only some papers and pen or a printer or computer. So the cost is 5. It's good for us. Leadership support, they will help us, so we'll put it 4 or 5. Time, it will take 1 week or 2 weeks issuing a policy, so it's 5 or 4. Accepted by the staff, staff will accept to do to issue a policy and the procedure, yes, and they can implement it if we have it because they are striving for this policy and the procedure, so 4 or 5. Now, if you want the total, you have to multiply cost by leadership support, by time, by acceptance, it will give you 400. The other choice, the other remedy, effective antenatal care, cost, it will cost us training for OPD, machines, a lot of things, it will give us a cost, so we will put it 3. Leadership support 4. Time, it will take too much time even to make coordination with the primary care centers. Accepted by staff 3, so the total is 72. Departmental orientation, do orientation for the physician. 5 because no cost. 4 because it will take leadership support time. We can do the leadership, the departmental orientation within 1 or 2 days. Acceptance, it will accepted by people, so the summation is, or the total is 320. Giving extra number of physician and staff to the department, cost, it will cost a lot to ask and to have recruitment, so it's not good for us, so it's 2. Leadership support, as you know, leadership doesn't like the word give us extra stuff, so it's 2. Time, it will take months to get a new staff. Acceptance by staff, it's 5 because they want a lot of staff, so they will accept it too much. So if you multiply this one, it will give you 20. So now you have 4 solutions. What you have to start with? You start, of course, with the big number here. So start with the policy, then the departmental orientation, then the effective antenatal care plan, then the 20. Not in sequence, but this is the importance. So you can work on the 4 causes at the same time, but you have to give priorities for your remedies to make it fast, which they are calling quick gains. I can improve the process very fast by starting with the big numbers: 400, 320, 72, and 20. Start with them all at the same time, but focus on the 400, then in the 30, 120, and 72, then 20. This is called the selection matrix. Now you have to plan. Plan means action plan. You have the solution, put them on action plan. This is the action plan as we inventing it. Issue policy procedure. Who will do it? The head of department in gynae obstetric. When we will give him time until September 5. Almost all the people doing improvement project will always forget the measurement. How to make sure that this step done already. The measure is to found a written approved policy, training record on the policy for the department staff, monitoring of implementation of the policy. 2, effective antenatal care. The one who will do it is the head of department of gynae obstetric department. I'll give him until 15 of next September 2020. How can I know that the antenatal care done? Through finding a plan, implemented plan. I can even put KPIs for the implementation of the plan. 3, we will do departmental orientation. It would be done by human resource department with the head of the department, September 10, for example. How can we do that? The orientation done by finding a certificate of training inside the personal file. By staff interview, I can ask them or give them written quiz about the orientation department. Giving extra staff to the hostel or to the facility, the responsibility of human resource. They will order, they will detect the number, they detect the qualification, and the hospital director will raise to the directorate or MOH. We will give them 3-4 months to put them. And how can I know? By finding extra people recruited inside the department. So this is the action. Do implement it. When you are implementing any recommendation, you have to start on a small scale, on only few departments or only few some days or weeks. Then you evaluate it. If it's going well, you have to generalize it or continue doing it. If there is some things or mistakes, you have to go back, correct them. Then you have to adjust your improvement project. Plan, then do implement it. Then check the results. Look what's happening. Did the improvement we implemented is going on or not? Do we reach the benchmark or not? Do we got our target we are planned in the first steps or not? So I will collect it and I will do a benchmark. Remember that our benchmark was 25 and we said and our target is to reach within 3 months below 30. After that, we can say below 25. So we collected data. Sorry, it should be here again, 2020. In August 2020, we found it 28%. In September, 25%. In October, 27%. So our project is working. So we have to keep working on the same recommendation, which is act. Act means maintain the gain, because the problem here is almost all the healthcare facility. When they do an improvement project and they will reach the target, everything will be vanished. They will stop doing the recommendation. They will stop to do the follow-up and keep monitoring. So we will go back to the bad numbers again. How we will contain or maintain the gain? Through ongoing educational training, monitoring through KPIs, review the policy, do staff satisfaction, do patient satisfaction, and continue doing the orientation program. Finished, alhamdulillah, we finished our simple explanation for a simple rule model improvement project. I'll give you here a gift for names, because some people will tell me that we cannot issue a title for improvement project. So I invented here some names for improvement projects. You can use them or you can adjust them to become suitable for your healthcare facility. I'll give you 10 examples. Number one, reducing healthcare associated infection from that number, which is bad number, to that number, good number, that you can do it through, you have to put time here. Two, increasing medication error reporting amongst physicians from that percentage to that percentage with that time. Reduce the bed sores inside our ICU from that number to that number through that time. Increase patient satisfaction for OPD services from that number to that number within that time period. Reducing waiting time in dental clinic from that days to that days within that time. Completing percentage of our staff files, medical records, or sorry, staff file, the files of the staff within that time. Reducing the TAT turnaround time inside lab from 60 minutes for state tests to 30 minutes by the end of next January, for example. Increasing physician documentation inside medical record from 60% to 80% within 3 months. Reducing VAB, ventilated associated pneumonia, ventilator associated pneumonia, to less than 10 per thousand, for example. I told you that I just invent numbers here to give an example to you. Mechanical ventilation days through 3 months. Reducing DAMA, discharge against medical advices, from ER from 36% to 15%.